All right, here we are. So we're back on and off we go. I took a look. It's interesting. The only thing that's interesting about, and I said it before, they tend to put eyes because they're a surface. And I always think that's more, I mean, obviously it's a crossover. But so when we get to the eye infections, it plays a little bit with respiratory and a little bit with skin. We have a minimum of, and this, as I scrolled through this PowerPoint, not recalling having not used Talon exclusively for about 5 years, because I was using it at two community colleges. I was adjuncting, and even when I was teaching here full time, keeps me out of trouble, extra money. And nevertheless, this actually wasn't too bad a PowerPoint. There's a few things that are missing that I think are worth going over, and I'll supplement that with Nestor. The odd thing, it's changed over the years, and I was just there's a disease that you have to know a lot about that for the longest time is considered a skin disease because of its hallmark, which is a rash. And usually that's the criteria, like measles or German measles or chicken pox. And that's Lyme disease. Now that and it's really probably more appropriately now considered an immunological disease because really it's your immune system basically doing the damage all over. But I'll mention it here so I don't forget to mention it subsequently. To that end, I also have, as you can see here, a basically a handout. It's 2 pages. So it gives you an idea. I guess you can see the Lyme disease and a few other odds and ends that are worthwhile looking at. So without any further ado, let us begin. And probably on Wednesday, I'll dart back and try to finish anything I don't really get done today uh, in that regard. So this is their 16. You have it on. It's all on week 4. Everything else is like that. Yeah. Okay. Skin is your strongest barrier. I don't want to rebuild the wheel. You all had skin in AP1. And you should have, and it's so important. Understand it's a 3-way barrier. It's anatomical because it's strong and dry. It's biological because it's covered in microorganisms. And it's chemical because of all the chemicals that you'll see enumerated here. Everything from topical antimicrobial compounds. It's salty, it's acidic, none of the things that bacteria particularly like, with the exception of staph, which is why that's public enemy number 1 for most of us. So it's the major boundary and all of these things. The interesting thing about skin is if we look at hair and sweat and oil glands, is those are little openings into the skin. So inherently, if your skin's damaged, you can understand why you would get an infection. But you have little openings there anyway that are ways for things to get in. And it's so easy comparatively. We injure our skin all the time. We brush it against things, whether you're shaving your face or shaving your legs, if that's what you're inclined to do. I mean, that's ways that can get in. You scratch, things get in. Sometimes you can't help it, but things get in there. So it's kind of interesting. You can see it's rather large. And the variation in thickness is more oriented toward the fragility of it. It's very easy for an eyelid with any minor trauma. I can't even tell you how many stitches I put in eyelids when I was a resident and how thick it can be when you get on the soles of the feet. And all of that has a lot to do with how long we leave stitches in. And you may have patients who would say, well, how long do the stitches stay in? Well, and these days it's changed a little bit because we have staples and all that type of stuff. But for traditionally eyelids, you're looking at 3 days. Bottom of the soles of the feet, plantar aspect, looking 14 to 21 days. It varies as time goes on. So and it's all about the thickness. Interestingly, the thick skin I always felt healed a little bit better. I was never shy about making incisions in the bottom of the foot, but a lot of people were. That's just me. And so you'll recall all of this. We're not going to go, you have millions of these cells. There's a lot of microbes that you're shedding. And since Staph aureus lives here on a great many of us for a great deal of the time, it's noteworthy. And more of it sheds when you have an active staphylococcal infection. And you can see it's replaced, depends on who you read, 25 to 45 days is fine. And you've seen that illustration. But inherently, there's a lot of openings for stuff to happen. Okay. And the other PowerPoint from Nestor talks a little bit more about normal microbes creating problems. That's particularly acne. there's probably some new information about how that worked. Acne and things like that are generally affecting sebaceous glands. They're plugged sebaceous glands. It's a problem that has to do, there's a variety of factors, not necessarily any of them hygienic, but if there's almost like an overreaction and an inflammatory response that occurs from the oils when they're trapped by certain inherently normal bacteria on the skin. And obviously, we all know people have been very, very troubled by that over time. The big player when it comes to the integrity of the skin, good old keratin, structural protein, it's very, very strong. Okay, and I'm not going to go over the strata again, though. I'm happy to do it again if you want. One of my favorites. It's one of those I can do it. It's like naming the bones and all the features. Do it in my sleep on my worst day. So, and the dermis is connective tissue. Two different types, you'll recall. Loose areolar, about 20% of it. Dense, irregular connective tissue. Lots and lots of cellular elements, lots of nerves, lots of blood vessels. Okay. And so, and if it gets into the dermis, we're going to have blood vessels that break. And if it gets into the deeper dermis, we're going to have scarring. And from structurally, that's how things heal. Blisters are interesting. They are really a separation of the dermal epidermal junction, and most of the time they're friction and pressure. They're side to side or torsional movement, and you see it all the time. Now it can happen because of other factors, toxins. So there's a relatively uncommon form of staphylococcal infection that you're going to see in a chapter called scalded skin syndrome. A limited percentage of staphylococci make a toxin that causes the skin layers to blister, and we rarely see it in adults. You see it, unfortunately, in newborns, and it can affect, because of the contagious nature of it, it can infect a whole nursery, and it's just like a burn. In a sense, it's not caused by a burn, but it can cause massive amounts of skin to slough, and that predisposes to infection and electrolyte imbalances and fluid imbalances, and children are at significant risk, babies, particularly infants, newborns. Okay, so, and then within the dermis, we have sweat glands and hair follicles and the roots that are associated with it. The oily based product of sebum, which is very much a holocrine solution, if you remember. It's like the whole cell breaks off, apocrine, just a tip of a cell breaks off, and merocrine or eccrine secretions are when little bits of fluid come off. That's what perspiration is. And the openings are significant. Just look at the defensive antimicrobial peptides, positively charged membranes, keeping microbial count relatively low, acidic environment, oily. Okay, the oily nature in certain areas. And as a general rule, what you're going to see, where are areas that are prone to infection, where they're oily or moist. Hair and around the base of the hair where it's oily. We call them intertriginous areas where skin rubs against skin, underarms, in the groin. People like me who have, as my dad used to say, avoir du poids. It's meant a little bit heavier than they should be. So you have that we call glabrous skin. That skin that's a nice word for saying, skin rubbing against skin abdominally in areas where it shouldn't. Not to be critical. It's all right. My wife's all over for me what I'm eating. Your diet's horrible. You're killing yourself. But I'm having fun. So all of that, and fatty acid metabolism inhibit the growth of microorganisms not adapted. What happens is, remember what membranes are. They're fatty acids. When you break them down, you have a certain amount of fatty acids that are released. That creates a certain degree of acidity. So it can be in some ways a nutrient, in other areas, and moisture is a big player in all this. Inhibitory, low acidity, high salt, again, staphylococcus. And you've done it in the lab. You used them. I'm sure you did. You used MSA, mannitol salt agar, the red stuff. Okay, that turns yellow for Staph aureus because it can basically ferment the mannitol and make acidity. And what we do inevitably in the laboratory with any of those media that are differential, we put in a dye that changes color most of the time. And that's the beauty of pH sensitive dyes that are there. And so we grow it. That's roughly 7% salt. That's a lot of salt. So we use salt-based augers to cultivate staph because they are also, because of that, you have augers that are designed for that purpose. They retard the growth of other things that are there. Lysozyme is there, breaks down peptidoglycan. Don't care, don't care. So, capable of living in dry, salty conditions. Flat, dry areas, less so. Dense population, moist areas, as I said. Ducts and hair follicles. So here are your defenses here. Normally on the skin, we see a variety of streptococci. We see a variety of staphylococci. Staphylococcus epidermidis, we used to call it Staph albicans because of the way it grows. White aureus because it has, in culture, or the pus that it forms is yellow in color. That AU thing up there. That's right, the periodic table. I had to mention it. Okay, so all those Corynebacterium and Propionibacterium, they are in the category of diphtheroids. They're gram-positive rods that look like diphtheria, but they're not. They're all over the place. Pseudomonas, which is a pathogen, but it's in the soil, and effectively it's on all of us. Lactobacillus on certain areas, typically moisture areas. Yeast, third to a half of us have yeasts all over the place. And it's not just Candida. There's a very interesting yeast who has my favorite name of all yeasts. Yeasts have a great name. For you fungi people, okay? My personal favorite, though, we don't do, and it can cause fungal infections, is called Scopulariopsis brevicalis. It's a name that just rolls over your tongue. We also call it SCOP for short. The other one, it's got two names, and they're the same. And it's on all of our skins, called Malassezia furfur. F-U-R, like furfur. Any fans of the Addams Family? You had to see Wednesday on Netflix. It was great. It's great. And the original Addams Family had Thing, who came along with Wednesday, by the way, in that Netflix thing. And he went by Thing T Thing. You know what the T stood for? Thing. You know, the hand. You can watch that show originally with John Aston and Carolyn Jones. Oh my God. And all the Wednesdays have gone on to have very interesting careers. Not as very unique careers, just saying. For you fans of the offbeat. Nevertheless, Malassezia furfur, which you'll see, causes a very interesting disease that I've seen in students. It's a skin disease, it's cosmetic. It's called tinea versicolor. And versicolor, with skin, what we utilize to evaluate skin is ultraviolet light. And certain infections glow certain colors. Versicolor means it grows different colors. And so, and it's a relatively easy diagnosis. It's more difficult to treat, but not problematic with topical agents, just as an aside. So, hundreds of different microbes, even pathogens, different layers, different areas, etc. Your microbes and my microbes, unless we have a significant change in our environment or our physical, something that affects us physically, typically stay about the same. So they're going to highlight MRSA in this. As you can see, they're going to look at the ways of transmission. They classify the diseases a little bit differently. They're going to talk about things called maculopapular and vesicular disorders and pustular disorders. And those are classic terminology that are utilized for skin. And you probably didn't get, it wasn't me. I didn't do it. On the skin, if you have a freckle, it's called a macule, okay, because it's flat. A papule, slightly raised. So when we have things on the skin that we recognize that have that appearance, called a maculopapular. When we see vesicles or a blister, pustules, self-explanatory, a little bit of pus. So vesicular pustular, chickenpox would be the poster child for that. Pox means pustules, and sometimes they're quite large. Then you'll see some pictures of smallpox. So you look at those different types of terms. There's a lot of older terms that many of you will run into in skin. Little tiny, like if somebody has an injury or maybe a blood vessels that weaken, we call them petechial hemorrhages. tiny little dots of red that happen. When they're together and they're larger, we have another name called purpura. And sometimes we'll see a very interesting allergic phenomena called Henoch-Schönlein's purpura that causes these big red blotches. So the terminology is something when you hear those terms, if it's one you don't recognize, look them up. Okay? For many of you in a clinical field that are going to do this. And here, the most famous, everything was based on measles. Measles, because it had a distinct ruby red, was named rubeola. And then when we got German measles, which was paler, it became rubella. So the color was often about that. Okay. So we start with what they call the highlight disease. Good reason. It's everywhere. I said it to you in antibiotics. We've morphed Staphylococcus aureus a couple of times. We've evolved it because of vast numbers in a relatively short time. Us evolving versus bacteria evolving. So now they're much more they're not the exception to the rule. They become the rule. And the harder ones to treat are in the hospital. And the ones in the community are becoming a more difficult issue to treat. Methicillin-resistant Staphylococcus aureus. That's what the acronym is. When we do wounds, you're going to see that it's not just Staphylococcus aureus, but the staph that's on all of your skin all of the time, Staphylococcus epidermidis. And what they used to do in the hospitals, I do not know if they still do that, is you'll classify diseases on patients as MRSA, if they're methicillin-resistant, or MRSA, MRSA and MRSE. And because in a hospital you have immunologically suppressed people with comorbidities, people who are sick, there's a reason they're in the hospital, they see a lot more normal flora infections. That's the Staphylococcus epidermidis. It's no easier to treat. Multiple resistance, we know what it is, gram-positive in clusters, doesn't move around, highly virulent, but normal in a third of the population, by whatever statistics they use here. If you work in a hospital or in a clinical environment, you have it on you much more frequently than that. 7.5 to 10% salt, extremes in pH, high temperatures. It's a very difficult to find an environment where it does not grow well. Viable after drying, resistant to a lot of disinfectants and antibiotics. That is it's a potential superbug in that sense. Hasn't gotten to that yet. Typical pustule that you would see. Raised, red, tender, localized lesions, sores, whatever you call them. Pus, feels hot, breaks in the skin, hair follicles. This would be, if it was a hair follicle, we call it folliculitis. Most of the times they open up and drain. If they don't, and it's deeper inside, now they've become something that we used to call a boil. So it's an isolated unit of pus underneath. And then sometimes the fancy name for that was furuncle. And then if you had clusters of those from multiple infections, and certain people were predisposed to that, they would be called a carbuncle. And you actually had to operate on those things to open them up, to let it to drain out. And you open them up, and you may end up with this. We do it with cysts, these large cysts of material that are becoming infected. You open it and you pack it. And you pack it and you gradually advance or remove the packing to allow it. You want things not to heal over the top. You want things to heal from the bottom up. You heal over the top, they just fill back up. Which is a whole idea with regard to that. So contaminant of all kinds of surfaces, gym equipment, heaven forbid you wouldn't go anywhere. It always drives me a little crazy on the plane. I don't get too worried about that type of stuff. Your skin's a pretty good barrier. But I mean, yeah, when I'm on an airplane, I see people who look like they're in an encounter suit. It's okay. Active MRSA should keep them covered to avoid transmission. So here you begin. Now they're looking at, typically they are hemolytic, and that's a tough distinction between Staphylococcus and Streptococcus because they both have hemolysin. So if you put them on blood agar and they're both in the throat, okay, it's very hard to tell the difference. That's where you do what's called catalase testing. In lab, anybody do coagulase testing? You did.
We have to do it for our mystery bacteria, but we didn't do it as part of this.
It's easy. I'll tell you the way I do it. maybe, who's your lab?
Trust.
Oh, yeah, Bill. So we're supposed to, not supposed to first name people, I think. He's even nicer than I am. And younger. Nevertheless. So, and there's a couple ways to do this test. I'll tell you the way I do it. So, when you have a gram-positive unknown, and there's a whole list, if you're nice, when do you have your lab? Okay. I can take a picture and send it to everybody. I've got like 2 pages that are like a laundry list for certain unknowns. Because I borrowed, not to say stole, from somebody else. Okay. And so with gram-positive cocci, the first thing if it's gram-positive versus gram-negative, if it's gram-positive, the first test is the catalase test, because effectively that distinguishes Staphylococcus and Streptococcus. Staph aureus and Staph epidermidis, the definitive test are two of them. Mannitol fermentation, okay, it's not 100% because certain gram-positive cocci, Micrococcus luteum, for example, will grow yellow anyways. It can sometimes surprise you. Is the coagulase. Coagulase is the number one, to me, virulence factor. What it does is it coagulates plasma. So the coagulase test, you get, the reason we don't do it a lot because it's expensive. We get frozen plasma that's freeze dried. We put sterile water in there. We shake it. You take about, like as you're showing here, you take about a half of a cc and you inoculate it. Some people think it'll coagulate right away. I think it works a lot easier if you stick it in the incubator in a test tube for a day or two and go back in there another day and check it. And when I mean coagulates, it'll have kind of lumpy or it'll solidify completely. That's the coagulase test. That's slam dunk for staph. If it does that and it's wrong, it means there was a contamination problem. And that's something we see in unknowns in the lab. Sometimes they'll end up being cross-contaminated. Just saying. So coagulase is the number one virulence factor, and there's others. Kinases spread things around. DNases, as you might suspect, break up nuclear material. Lipases, fat. Hyaluronidase. Hyaluronic acid is a major component or constituent of connective tissue. So they're spreading factors. And if you think staph has a lot of them, Streptococcus has more that are there. So, I mean, yeah, we have PCR, but they're not going to do it for your lab. Blood agar or mannitol salt. Catalase distinguishes, this is incorrect. It distinguishes Staphylococcus from other staphylococcal species. It does not distinguish Staph aureus. The coagulase test does that. So I noticed that the other time. So it's good stuff. It's all about hygiene. IND, incision and drainage, is something that we do, like for boils or something like that. Okay. Again, you don't just jump to Vanco. Most places don't do that. It depends on who's doing the treatment, I would suppose. But I understand, like I said, there's a pecking order. Typically, when you're looking at MRSA, I personally start, if it's community-acquired MRSA, I would start with those combination sulfas, Bactrim or Septra, trimethoprim and sulfamethoxazole. Then I would ramp it up to something like clindamycin. Then I would use like Synarcid or linezolid or one of the other ones. And then I would ramp it up to vancomycin. Maculopapular, flat to slightly raised colored bumps. That's a good way to express it. Bumpy. Measles, rubella, German measles. Fifth's disease, which you'll see an illustration of, is called slap cheek syndrome. Okay? And that's the one that's caused by a herpetic virus is coming to me. No, it's parvovirus. It does that. Okay, so measles. Very interesting here about measles. Measles is another one of those resurgent diseases. You might remember early on I spoke to you about that. In this country, vaccination laxity. Okay. In other countries, unavailability of vaccines, distrust of vaccines, unable to afford the vaccines, overcrowding, all of that type of stuff. Rubiola was the original name. So, per day, even though an extremely effective vaccine has been available since, okay, 1963, it is a big killer. I say this in every single micro lecture for the 20 years I've been doing it. It's the third largest killer in equatorial Africa. Malaria, HIV/AIDS, that's vaccine distrust. That happened, what we think started with HIV was when they tried to make polio vaccine contaminated with a monkey virus. It hybridized, most likely, and created the scary human immunodeficiency virus. Because it's a virus that's got DNA characteristics and RNA characteristics, and we classify in COVID terminology as a novel virus we'd never seen before. And they began to immunize people for polio, and 35% of equatorial Africa is HIV positive. Go figure. So why would they trust the measles vaccine? Before the vaccine was introduced, measles killed 6 million people every year. Every kid that when I grew up, okay, we all had the measles. Everybody. I got them, I think it would be 1957. I know. Don't start. Okay. Sharp increase in the United States since 2019. That's in the US, that's vaccination laxity. Massive measles epidemic on Samoa, 5,600 cases of measles, 81 deaths. It's not innocent. People lost track of it. It's a significant respiratory involvement, pneumonia like, with a lot of complications, infections from scratching. It's very itchy. So it's got mold. It's not just something where red spots go on your skin. For us, we got a bunch of red spots on our skin. Mom said, "You stay in bed or I'll kill you," and she meant it. Okay, and all you had to do was sit there and watch TV. I can live with that. In fact, that's my default. So it starts respiratory, sore throat, cough, paramyxovirus, conjunctivitis, lymphadenitis, swollen glands, fever, 102 to 104. One of the diagnostics, the mouth is a wonderful area for looking at systemic disease. You can see a lot of it. Classically, Koplik spots look like little, coarse salt granules or plaques, sort of between the molars and the gum. So it's something you look for. And this red maculopapular, fancy name, exanthem, that it erupts on the head and progresses to the trunk. So it starts here, works its way out. Those are little tells. Sequelae and complications: laryngitis, albeit pneumonia, ear and sinus infections, more pneumonia, encephalitis, permanent brain damage, and an oddball that you'll see here called SSPE, subacute sclerosing panencephalitis. I don't see a lot of that. One in less than 1,000 children who get the measles before being vaccinated. The virus is defective, spreads unchecked, affects myelin, profound intellectual and neurological involvement, almost always fatal. It's a rare, again, that's something in sub-Saharan Africa where you have a large amount of cases. You would see that. In this country, maybe we were looking at 1 in 100,000 before the measles vaccine that was available. We didn't have it. I think I told you, we had chicken pox and measles parties. Moms wanted you all to get it. I told you that story. They took us to the circus in the old Madison Square Garden on 50th and 8th Avenue. Everybody got on a bus trip. Everybody got candy, got ice cream. Happy dance. And measles. Moms were happy. Child abuse. That's what they tell you, Ruth. It's okay. Okay. Respiratory mucosa, tracheal and bronchial, lymphatic traveling, viremia, viruses in the bloodstream. Adjacent host cells fuse, syncytia. This is something viruses do. They cause fusion, respiratory syncytial virus for the newborn or croup in this same category of paramyxoviruses. Okay. One of the most contagious diseases. You cough, you sneeze, it's transmitted human to human. It's contagious incubation when it's starting before you know you have it. The prodrome when you're just starting to feel sick. When you have the rash, but not so much during convalescence. And so once you're basically over everything, then they send you back to normal activities. There's a lot of ways to diagnose it. Again, the MMR, measles, mumps, and rubella, what they call, see, to me, this is the misnomer, live attenuated viruses. Viruses aren't alive, but that's the way they label it. I think there's an active attenuated viruses, but who am I? Okay. You can see where the scheduling is, and all of these types of things is pretty much standard. The vitamin A is interesting. I obviously, as if it's part of it, I can't, off the top of my head, tell you why. German measles had that too. I got that when I was 16. Name derived for Latin for just slightly red, comparatively minor. You wouldn't even know you were sick. 101, 102 fever. I can still to this day feel the preauricular nodes that are back here behind your ear being all swollen and painful. Okay, the big problem, it's highly contagious and it's contagious before you know it. Okay, and before you have any symptomatology, anything that appears, and that because it's contagious so well, if you're coughing or sneezing around somebody who's pregnant or is close to somebody who's pregnant, big trouble. So, women of childbearing years need to make sure they have been immunized for this. There are so many problems that are associated with it. This probably caused, we called it, it's why there were so many, it typically attacks special senses. There were so many hearing problems, some visual problems, but more hearing problems than anything prior to that. When we were kids in grade school, so many kids were in speech, so many kids wore hearing aids. It's what they did. Rubella, there's no question in my mind about that. Very pale rash, hard to see, resolves quickly, much milder. In adults, all of these are worse. Anything that happens in an adult is worse than in a child because we can't tolerate the high fever or the problems. This is the idea of being teratogenic. And they should always show you this illustration because it affects neurological things. And so here you're probably meningitis or encephalitis, something that's that. Mother to fetus in utero, even if the mother is asymptomatic, infection in the first trimester, miscarriage, multiple defects is what we saw. Deafness, number one. All these other things that can occur with regard to it. It was different. They didn't mainstream as many kids. There was more institutionalization, which has become more frowned on over time. So most of the kids that we went to school with were normal kids with problems. One of my best buddies always had speech problems. And became a very successful attorney. Wasn't that limiting, but they were always going in speech things. Other sequelae that you can see here. It's a toga virus, stops mitosis for development, apoptosis, vascular endothelium, poor development, blah, 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 blah. Worldwide, contact with respiratory secretions, urine potentially, more probably respiratory around for us. As you can see, spread even during the prodrome and up to a week after the rash. Congenitally infected longer, moderately communicable, so it's close conditions. Okay, as you can see, we rarely see it. That's a very, very successful immunization that's there. And the way they diagnose it, again, they're given simultaneously 12 to 15 months with the booster, which you folks undoubtedly had. Fifth disease, my kids had this. Slap cheek syndrome, because it's very distinctly looks like a slap cheek. Parents are always afraid to bring your kids to the ER because they think you're abusing them. Again, we were hoping they'd take the kids. Because you get them back the next day. Take my kids, please. Still. Other than my daughter, who's nice. Two days, spreads, fever, lingers, comparatively minor. It's a parvovirus. is contagious. It's really not a big deal. It's noteworthy because years ago, why they call it fifth disease, we used to number these. Number one, scarlet fever, and number one, measles. Number two, scarlet fever. On the other PowerPoint from Nestor, it has that numbering system. So it was named because it was the fifth most common of these diseases. They called it fifth disease. They really probably didn't know a lot about it. And my kids had this roseola. What's interesting that the fever is scary. This is a herpetic virus, HHV6. Most of us have been exposed to it. The oddball thing, and you might remember me telling you this when we did herpetic viruses, herpes viruses, we see a fairly high correlation with people who have titers of this with MS. It's something that's being studied. Are certain people, when they are exposed to this, and effectively we've all been exposed to this, more likely to start with MS. MS is a very interesting and complicated disease. So, sixth disease, six on the list, high fever, the rash, okay, typically occurs after the fever breaks. So you think your kids are going to die. 104, 105. That's, 104 isn't going to put a kid in the hospital. Would put you and I in the hospital. 105, now you're really getting scared. Seizures, and then it disappears in the rash, chest, trunk, less prominently on the face. So it's more, and that was usually the tell. As the fever started to break, you always see into the rash here, and the pediatrician or family doc would go, roseola, we're okay. And so it's something all my kids had. Latent in the host indefinitely after because it's herpetic. Reactivates potentially like all herpes diseases, the latency period. That's an interesting number. What they're studying are, I'm sure, tighter levels of antibodies because MS is in that autoimmune. You did the immune unit, and the autoimmune diseases are fascinating. Okay, why your immune system goes wacky at times like that. And I don't have an explanation. But if MS is anything, it's probably underdiagnosed. But a lot of us have aspects of it that might meet diagnostic criteria, but it doesn't really affect us so much that are there. When we hear it, we think it's immediately life threatening. It's not necessarily. So half the people who have it aren't really affected. Doesn't really dramatically affect. From my perspective, the things that really impact you, and you'll all learn about this, are things that, and about half the people are impacted this way with autoimmune diseases. It affects what are called activities of daily living, ADLs. Dressing, washing, being able to go to the bathroom, being able to clean yourself up after going to the bathroom. All of those kinds of things. Going in the kitchen, when it affects that, that's a life effector. The basis of occupational therapy is to improve people who have limitations of their ADL. These days, it's become mostly hand upper extremity oriented. But effectively, that was the original distinction of occupational therapy. There's physical therapy, occupational therapy, and for severely injured people, there's something called restorative therapy. And they may have put a lot of these together or changed the diagnoses over time. Impetigo. So it's impetigo is both staphylococcal and streptococcal, and may even be a mixture of the two. It's superficial. It's typically we see it on the face for a little scratch or a bug bite. A child will scratch, and what happens is it kind of weeps a plasma that becomes somewhat golden yellow. And there's a better illustration in the Nestor PowerPoint. Watch out. The staphylococcal one responds. It's not typically MRSA based. It's treated either topically or both topically and orally with antibiotics. The streptococcal one is a big problem. That's one that's associated most commonly with acute glomerulonephritis. I can't even tell you how many students or people I knew who had impetigo as a kid and ended up with their kidneys shutting down. Those big autoimmune complexes, which you see associated perhaps more so with this than with a typical strep throat. Strep pyogenes begins, later Staph aureus, that destroy its toxins, destroy the strep pyogenes. crusty, honey-colored, just golden yellow, typically around the mouth and the face, sometimes the extremities. Exfoliative toxins, gram-positive beta hemolytic strep pyogenes, good old strep throat strep, with this variation. Pharyngitis, same one that causes pharyngitis, scarlet fever, puerperal sepsis, childbirth fever, neck fash, which we'll talk about in wounds, and all those post-streptococcal things. The big deal is right there. Acute glomerulonephritis, kidneys shutting down. Rheumatic fever can also be, but rarely so, is more often the case in newborns. Staph aureus a little bit older, but both. Something we do see with streptococcal infections, unfortunately, I had this ever so briefly, but it did kind of put me, I think I was still, I was just started teaching here, is cellulitis. We used to see a lot more. Cellulitis is it's like an ascending redness that moves very, very quickly and is inevitably streptococcal. And it starts usually with a sore in the leg or the arm, and this is where mine started. And I ended up with 103, 104 fever. I opted to refuse admission, the invite over at North Hills Pacific Hospital. Okay. Pain, tenderness, and swelling. I did not have the lymphangitis. It was a very interesting diagnosis. The ER physician just he must have seen one before that looked like mine and said, I think this is what it is. It turned out what it was. Okay. Uncomplicated is what mine was. So it responded well to basically Keflex was able to, and because thankfully streptococci are still very, very responsive. Strep pyogenes, sometimes staph. I wasn't immunocompromised at the time or anything like that. Group B streptococci is unusual. We see that in infants. So mine was probably no obvious break in the skin. We used to see a lot of it. We'd have people on mega doses of penicillin back in the 1970s when I was a resident, because it was all sensitive to good old penicillin G, something that we use very, very infrequently. I mean, we used to give to somebody, we use what are called international units. So 1.6 million international units is equals to a gram. We'd have people on 20 million units intravenously 3 times a day. So it depends on how extensive it is, how you would treat it. And maybe we'll conclude with, may have time for one more. This is the dermolytic one. It affects mostly newborns, can affect adults. The skin would blister and fall off. Obviously, this does not appear to be a newborn. It would separate the epidermal dermal junction. So you have blisters. So it starts with vesicles, then you have blisters, then you have bulla. A bulla is a large blister, like big blisters that are there. Neonates umbilical or in the diaper area. Wide desquamation using all those squamous cells. Immediate antibiotic therapy. This is life-threatening because fluid and electrolytes that are there. Caregivers, adults in the nursery can transfer it. Asymptomatic carriers, a real problem. Mostly a clinical diagnosis, and you've got anybody who potentially could be a carrier. You have to keep them away from neonates because it can go right through a nursery that are there. Systemic antibiotics. So, and there's a better picture. And then this brings us in, it's just an introduction into what are the classic pox, which was implied pustules. Chicken pox, again, all of us had that. The immunization, I think, started in 1985. All my kids had it. Okay. Interestingly, 1995, I think, was that immunization. My kids had it all in the same year, 2 weeks apart, in order of age. Oldest, age 5, next one, age 4, next one, age 2. All different presentations. Okay. They start as a rash. It's just that smallpox is life-threatening, and you won't see it. Theoretically, it's been evaporated. So individual lesions that contain fluid are the way it is. Fever and abundant rash appears after X amount of incubation. My kids were almost exactly 2 weeks apart. That falls into that. Starts facially, sometimes trunk, and begins to spread out. That's one of the tells that are there. Progress quickly from macules to papules to blisters that are itch, and out, boy, are they itchy. So the treatment of choice and the original Aveeno product line was called colloidal oatmeal. So what it was you poured it, because like, oh, we're not making oatmeal at home. I'm fine with it. Not those little packets. So I don't mind those. I like the stuff in the big, the Quaker Oats guy. Like that. And you pour the oatmeal into the bathtub and you stuff your kids in there and let them soak because it would stop itching. When I was a kid, it was all calamine Caladryl lotions, which aren't necessarily as effective as this. So we used a lot of colloidal oatmeal and threatened to kill them if they scratched. Unfortunately, they still scratch. When they get crusty in a few days, 3 to 5 days, if they scratch them, you can get scars with it. Hundreds of them, more so as you get older. Centripetal, so it's more centrally placed than extremity wide placed. Okay, after about 5 days. And the tell when you could go back to school was they all crusted over. And that was when it is. Very rare encephalopathy. It's still a viral. I mean, it's when my middle one was exposed to chickenpox. I think I told you this story. He was being worked up for gastrointestinal problems at the old Children's Hospital, which is right next to Presbyterian. Okay, whichever they've expanded because they took over St. Francis up in Lawrenceville and made that into Children's. And he was on the floor because he was clean. He was just doing GI workup for a couple of days, doing endoscopies and things like that. A kid at the local Y had chickenpox. We immediately told them about that. All of a sudden, we're in reverse isolation. They won't let him go anywhere without being covered in all sorts of stuff. Couldn't leave the room otherwise. I slept in the room with him every night. That was there because on that floor, liver transplant kids, major orthopedic trauma cases. A liver transplant kid gets chickenpox, they can die. And soon. So just to give you an idea. So we'll stop there and we don't want to give short shift to shingles. Say that 3 times fast. Short shift to shingles. Tell everybody else, look what they missed not being here. Nice not seeing any of you.